Hello and welcome. We are honored to have the chance to speak with Dr. Benita Shaw today. Dr. Shaw is an associate professor of medicine at NYU School of Medicine, where she serves as director of research for interventional cardiology at NYU Langone Health and co-director of research at NYU Langone Health. Dr. Shaw's clinical translational research brings a multidisciplinary approach to coronary artery disease and acute coronary syndrome. She has led numerous high-impact studies and serves on many national committees, including the American Heart Association's Leadership Committee of the Council of Clinical Cardiology. We are thrilled to have Dr. Shaw here today to share her wealth of experience and contributions to the field of cardiology. What are your thoughts on inflammation in the Southeast Asian community, and how did it inspire you to work in this field?
There's a whole science behind this that there's actually a woman at Northwestern who studies this extensively, looking at the epigenetic changes in South Asian patients. And you can see that the adipose tissue sort of concentrates in the belly. So you have this protruding belly, which is a real setup for both glucometabolic abnormalities as well as a higher inflammatory risk.
How have you seen the field of cardiovascular disease evolve, particularly regarding the understanding of inflammation and what that looks like?
We've seen a tremendous amount of progress made both technologically and pharmacologically in the field, and it's really been a lot of great progress. Technically speaking, our newer second-generation drug-eluting stents are better than ever, safer than ever. We've made a lot of optimization in technique using intravascular imaging and intravascular physiology to optimize our stent results. And then pharmacologically, we have new potent P2Y12 inhibitors that we can use in the acute MI setting. We have more intensive lipid-lowering therapies outside of statins alone. We've made progress in diabetes management as well as modifying the glucometabolic milieu. But, as we now have a study that confirms the inflammatory hypothesis, the role of inflammation independent of LDL in adverse outcomes in patients with cardiovascular disease. But we haven't made much progress in terms of therapeutic options here. We do have colchicine available in patients to reduce their residual inflammatory risk. That again is independent of LDL, and that is indicated in a fair number of patients, however, is limited in the CKD population. And so I hope that you'll join us at one of our Learning Studio sessions, Systemic Inflammation, evaluating potential new targets in the management of atherosclerotic cardiovascular disease and CKD. Our patients with CKD have a huge gap in therapies, and we need to know more, not just in terms of other therapies to lower inflammation, but particularly as well in patients with CKD. And this will be taking place at the American Heart Association Scientific Sessions. I hope you'll be able to join us.